Thank you so much, dear professors and dear colleagues. And thank you so much to Professor Assam Bidewi, my good friend and my brother, for allowing me to contribute in this amazing work. It's a pleasure to be here among you today. Actually, we have, I'd say, a rather difficult topic. So try to be precise and let me know past my. Neuroendocrine tumors are a set of tumors that is found all over the body. Okay, most they are found in the gastrointestinal tract. All share some criteria. Most are small, less than 1 centimeter. They are growing, and they are sometimes metastatic, and why they are sometimes misdiagnosed. Arise from neuroendocrine that's job is to synthesize and secrete neuropeptides. Okay, and if they are secreting tumors, then they are considered symptomatic. If not, they are considered non-symptomatic or non. We take a look at, as I mentioned before, that the cells are distributed all over the body, and mostly they are found in the gut, in the GIT and the pancreas. And the second most important site is the lung. Okay. Do we have a specific reason why do we encounter or why does neuroendocrine tumors happen? الحقيقة لا. ولكن they are connected to certain inherited genetic syndromes. 4 of them. The MEN type 1, the multiple endocrine neoplasia type 1, von Hippel syndrome, neurofibromatosis, and the tuberous sclerosis complex. Other than that, sporadic or non-hereditary mutations can be risk factors for neuroendocrine tumors. Okay. الحقيقة, what we are trying to target in this session, or I'm sorry, in this lecture, is to formulate an algorithm how to diagnose and how to manage neuroendocrine tumors. For us to do this, we need to classify neuroendocrine tumors, and upon this, we will know how to manage this. Number 1, it's according to the site of origin of the tumor. Number 2, it's according to the extent of this tumor, whether it is confined to the main organ or it is extending outside of it. Number 3, it's the grade. And 4, it is the histology or the morphology that dictates the aggressiveness of the tumor. And finally, what I have mentioned before, whether it is symptomatic or not. So let's take a look at the sites where neuroendocrine tumors happen in the gastrointestinal tract. We have 6 main sites, although it can happen anywhere. Okay. So basically, it is the gastric type, small intestinal, pancreatic, colonic, rectum, and the appendix. And please never forget the appendix, because sometimes it is missed. Okay. Let's go to the extent. And this is quite important, because according to the extent, we will decide the type of treatment that I'm going to follow. The extent is basically built upon the idea of the TNM staging. And I think this is well known to all of us. The TNM staging, it refers to the tumor itself, whether it is confined to an organ or extending outside, if there is lymph node affection or not, and finally, if we have distant metastasis or not. And this has been addressed in so many guidelines. يعني الحقيقة, they compare to each other, okay? And the most important thing is that they have the rule of 2. If it is less than 2 centimeters, this is T1. More than 4 centimeters, this is T3, I'm sorry. And between this, between 2 and 4, this is T2. And if there is invasion, this is considered T4. Okay. طيب. Let's take a look at the histology or the biopsy of this tumor. We depend on two things to assess neuroendocrinal tumors. The mitotic rate, which is defined as the number of mitotic figures per 10 high power fields, which is 2 millimeter under the microscope, and the Chi 67%. El Chi 67 da? This is a protein that is closely related or found in high proliferation in malignant cells. So the job of the pathologist, which is crucial or very, very important in cases of neuroendocrinal tumors, is to assess the mitotic rate and the Chi 67 index. And according to this, we categorize them to grade 1, 2, or 3. And this has been a debate over the years. And the WHO has proposed many categorization over the years since 2000 and then 2010, as we see in here. And then that was updated in 2017. طيب ايه اللي اتغير ما بين 2010 و 2017? The basic idea is that they divide them into well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. In 2017, they added grade 3 in well-differentiated tumors. And then in poorly differentiated, they divided the grade 3 into small cell type and large cell type. And again, why are we saying this? What is the benefit of this? This will help with the treatment decision. Okay, let's take a look even deeper, ultrastructurally. What will we find? الحقيقة neuroendocrine tumors, they are secreting cells. They arise from secreting cells. Okay? So those cells, they have granules secreting neuron-specific enolase, NSE, and chromogranins, especially chromogranin A. Those are non-specific, but we have specific hormones that arise from pancreatic neuroendocrine tumors, from the beta cells like insulin, from alpha cells like glucagon, gastrin from G cells, etc. Those are specific hormones with certain symptoms that I can detect, which dictates the clinical suspicion that this patient has this type of pancreatic neuroendocrine tumor. Okay? I will not go through the details of every disease, but for example, like in insulinoma, we have high levels of insulin. Okay? So the patient will complain from mainly hypoglycemia. In gastrinoma, we have high levels of gastrin, so the patient will present with Zolliger-Ellison syndrome and diarrhea, etc. So the specific hormone dictates the disease, شكل الديزيز. So I have to be aware, I have to keep this in mind. ايه هو السيمتوم اللي البيشنت presenting بيه. Finally, to fulfill this classification, we categorize neuroendocrine tumors into symptomatic and non-symptomatic or asymptomatic, functional and non-functional. ايه ميزة وعيب كل واحد؟ الحقيقة the functional or the symptomatic tumors, we can detect them a little bit earlier because they have symptoms. So I can encounter the patient at an earlier stage due to the secreted hormone. Insulinoma, I can detect hypoglycemia. What about asymptomatic tumors? صحيح هم ممكن يكونوا non-functional, not presenting with symptoms, but they get to increase in size, the bulk effect. And even I can encounter them when the patient بقى عنده metastasis. So بكتشفهم الحقيقة late شوي. طيب, out of what we said, هل ده يؤثر على البروجنوزس؟ Actually, yes. The invasion, هل this tumor is invading any organ outside؟ هل في lymph node affection or not؟ هل في metastasis or not؟ هل في comorbidities or not؟ And the surgical margin, هل أنا قدرت أعمل في السيرجري complete removal للtumor or not؟ based upon the curative treatment in neuroendocrine tumors is surgery. So upon this, the WHO again proposed whether this tumor will be benign or malignant or highly malignant, etc., according to this or those items of classification we have mentioned before. Okay. بناء على this classification, we have to propose an algorithm for diagnosis. طيب. Diagnosis of neuroendocrine tumors is not always easy, and it has more than one modality that we have to combine together for us to achieve this diagnosis, especially if it is non-symptomatic or asymptomatic. Okay? So it is biological, it is endoscopic, imaging, etc. In a specific hormone presence, you will encounter specific symptoms. So clinical suspicion that this patient has this or that will help you. But sometimes in asymptomatic neuroendocrine tumors, I have to order the general markers like chromogranin A and enolase. Okay. For example, gastric neuroendocrine tumors, definitely we cannot go into the details of everyone علشان الوقت. But the gold standard for me to diagnose is combining upper endoscopy and EUS. What's the benefit of upper endoscopy? I can detect lesions that are small, less than 1 centimeter. I can take a biopsy, so I can know the grade, the histology, the differentiation, etc. طيب, if I have a lesion that is a little bit bigger, more than 1 centimeter, definitely you have to use EUS. ليه? To detect invasion, to detect metastasis, to check for the lymph nodes in this area. Okay. الحقيقة إن sometimes it is a little bit difficult, or sometimes they are far beyond reach of the scope. Therefore, I have to use other modalities, like the somatostatin receptor scintigraphy, SRS, أو الأوكتاليوسكان Okay? This will help in detecting lesions beyond the reach of the scope, detect even smaller lesions, and detect lymph node affection. And this should be combined with other modalities like triphasic CT or MRI. What about functional neuroendocrine tumors? Actually, I will not go through the details in here, but definitely you have to know the incriminated hormone and what kind of symptoms that will present. وإيه هي أهم sites for this problem or this neuroendocrine tumor. Let's take a look at the two most important or the two most common neuroendocrine tumors. Number one, insulinomas. Insulinoma, according to the guidelines, they have 6 criteria to diagnose. أهمهم هو إن أنا I order C-peptide proinsulin and beta hydroxybutyrate. Other than this, I have to detect the blood glucose level, the insulin curve, and the absence of metabolites of sulfonylurea. Okay? الحقيقة, for me to do this, or to order this needs someone who's an expert in clinical pathology because it needs some kind of a supervised fasting. I have to do an adequate insulin curve, okay, for us to diagnose this. As for gastrinoma, I will detect high level of gastrin, hyperchlorohydria, and basically I have to detect this by measuring the pH of the stomach that will be less than or equal to. Again, I have to combine this with triphasic CT, MRI, etc. As for rare types of functional pancreatic neuroendocrine tumors, we have the vipoma, glucagonoma, and somatostatinoma. And again, according to the specific hormone, we will order the specific lab test and the imaging needed. طيب. As for the non-functional ones, هنا الحقيقة إن imaging has a huge role because they are non-functioning. So I will order the non-specific hormones like chromogranin A, okay? And I will use the help of MRI, CT, or endosonography. Luckily, أو يعني مش دايما luckily, الحقيقة إن إحنا we encounter the non-functional types بس بتكون كبرت، فممكن يكون الموضوع late شويه and sometimes even metastatic. طيب as we said we're trying to propose an algorithm. هل اقدر استفيد بالبيزلاين investigations in a patient with neuroendocrine tumors؟ yes. ممكن يكون عندي clinical suspicion according للي انا بشوفه في اللابس بتاعت البيشنت زي anemia. It is found in different malignancies. A patient with diarrhea زي العيانين بتوع الفايبوما بيكون عندهم hypokalemia, acidosis with severe diarrhea. In cases of metastasis to the liver هلاقي affection liver function tests والliver enzymes. البون بروفايل والهايبركالسيميا in men type 1 and metastatic diseases, and definitely the panel of blood glucose كله من اول hemoglobin A1C, الانسولين كيرف etc. and in glucagonomas بيكون عندنا glucose intolerance. Actually, if we suspect neuroendocrine tumors, we have to order the full panel of hormones, including the chromogranins A and B, and the patient should be fasting for 12 hours. Please remember to stop the proton pump inhibitors and H2 blockers, and you can find the 5-hydroxy-indole acetic acid in urine in patients with secretion of serotonin. هل في حاجات further عن كده؟ Yes, الحاجات اللي احنا we went through before. Remember, in the lung is one of the main sites or the important sites for neuroendocrine tumors. So order please chest imaging. As we said, the upper endoscopy is quite important, endosonography, and sometimes enteroscopy is of great value. في بعض الحاجات the surgeon might need to delineate the part that he needs زي ال selective venous sampling of the pancreas using calcium infusion علشان الاناتومي، كذلك الميتا ايودوبنزايل جوانيداي سكان والاوكتاريوتايد ابتيك سكان. كل الهدف منهم ان انا اعمل anatomical delineation للتيومر. Finally التريتمنت as we are يعني short in time، هو ايه هدف التريتمنت وبيكون based على ايه؟ Neuroendocrine tumors, if they are non-functioning, then I have to remove it. Done. If they are functioning, then I have to get rid of the symptoms. So, treatment is either non-pharmacological, which is surgery mainly and radiation, pharmacological like targeted therapies and somatostatin analogs. الحقيقة إن surgery هي is the key point treating neuroendocrine tumors. So I have to get rid of this tumor, even if I cannot remove it all, because in secreting tumors, in symptomatic tumors, you will decrease the symptoms markedly if you can remove a large bulk of the tumor. So the surgery can be either curative or palliative. If not, and if there is metastasis, we use local regional like ablation or embolization like we do in HCC. Radiation, it is not that powerful or effective in those types of tumors because they are resistant to radiation. Just use it as a modality just to يعني in incomplete action. طيب finally الفارماكولوجيكال تريتمنتس اهم حاجه هم التارجت ثيرابيز اللي هم بيكونوا انتي بروليفريتيف زي الافرالومس والساتينيب، بيكون هدفهم ان هم يكونوا انتي بروليفريتيف regulation of apoptosis, so I can use them after surgery. ايه الفرق ما بينهم؟ الحقيقه ان الافرالومس هو اللي بيكون عليه ستاديز اكتر ان هو فيرست لاين اوف تريتمنت، بيستخدم في الانريسكتبل اور ميتاستاتيك ديزيزز او لما يكون انا ما قدرتش اعمل كومبليت ريسكشن. كذلك نفس الفكره في السانيتينيب، بس هو الحقيقه لم يستخدم قبل كده كتير as a first line. Finally, octarioptides are used to control symptoms in most of secreting tumors زي الفايبوماز, insulinomas, etc. This is an algorithm proposed بناء على what we said. بس يعني we are short in time, ف thank you so much for your listening.
Thank you, Dr. Mohamed Negm, for the nice demonstration of neuroendocrine tumors.